Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Importance of Prostate Cancer Screening, presented by Dr. Stephen Curran, family physician with Washington Township Medical Foundation. Dr. Curran is board certified in family practice. He completed his undergraduate training at the University of Nebraska in Omaha. He received his medical degree from Washington University Medical School in St. Louis, Missouri, graduating in the top one-third of his class. Dr. Curran completed his residency at the Family Practice Center, East Carolina University in Greenville, North Carolina. He has extensive knowledge of occupational and industrial medicine. Dr. Curran enjoys travel, hiking, fitness, and spending time with his family. Please welcome Dr. Curran.
Well, thank you. I'm Dr. Stephen Curran, and proud member of Washington Township Medical Foundation. I'm here to speak to you today about the importance of prostate cancer screening. So first, some scary statistics. Prostate cancer is actually the most frequently diagnosed cancer in 112 countries and the leading cause of cancer death in about 48 countries. It's the fifth leading cause of male cancer-related deaths worldwide, with more than 1.4 million newly diagnosed cases and over 375,000 deaths reported every year. And according to the American Cancer Society, prostate cancer is the second leading cause of male cancer-related deaths in the United States. There were 288,000 new cases and over 34,000 deaths estimated in 2023 in this country. And data from the National Cancer Institute reveals that the average American man has about a 13% risk of being diagnosed with prostate cancer over their lifetime. In other words, about a 2.5% overall risk, 1 out of every 41 men, of dying from it. And it should be known that the incidence of prostate cancer in black men is actually about 70% higher than in white males. And the lifetime risk of dying from prostate cancer varies in different ethnic groups, with black men living in the U.S. having the highest risk at about 4.2%. And according to the National Cancer Institute, the median age of death due to prostate cancer is about 80 years old, with 75% of the prostate cancer-specific mortalities occurring in those over 75. In other words, it's typically a cancer of older men, but unfortunately it can affect younger men as well, and often in younger men, the cancer tends to be more aggressive. The average age at the time of diagnosis is about 66 years old. And data suggests that most men will die of other causes before their prostate cancer becomes advanced or clinically significant. But as I'll talk about, that's the real challenge with prostate cancer, is figuring out how to diagnose the clinically important prostate cancers at an early stage where our interventions will have a positive outcome. So again, routine screening for prostate cancer is actually somewhat controversial. And so we talk about the concept of shared decision making. And it's strongly recommended before starting or discontinuing prostate cancer screening. Shared decision making, well, in the old days, we might put doctors up on a pedestal and just listen to everything they said and follow without question. But that certainly doesn't make sense anymore. Shared decision-making basically involves doctors listening to patients and patients listening to doctors and coming up with a solution together about what's the best way to proceed. So the American Urologic Association study on implementing shared decision making came up with the following features. Both the physician and patient should be involved in the decision making process. Information should be freely shared before the physician and the patient. Consensus should be built through the free expression of preferences, and the physician and patient should agree on implementing the selected plan. So how to screen for prostate cancer? Well, the typical has been the PSA blood test. So PSA stands for prostate-specific antigen. It's actually a protein made by the prostate gland, and PSA levels can be measured in the blood. And the levels increase in both malignant, meaning cancerous, and benign prostatic conditions such as benign prostate hypertrophy or hyperplasia, which is basically just the normal prostate enlargement of aging. Prostatic inflammation or infection, like a prostatitis, could also cause your PSA to go up. And even just trauma or ejaculation or sexual activity could cause a temporary bump up in the PSA. And it's important to know most men with an elevated PSA will not have prostate cancer. But also it should be said that a normal PSA value does not rule out prostate cancer. Hence you could say that the PSA test does have a lot of false positives, false negatives, but right now it's still the best we've got. We should note that screening based solely on PSA level has demonstrated fewer prostate cancer deaths and a reduction in the incidence of metastatic disease related to prostate cancer. 25 to 40% of men with an initial elevated serum PSA level will demonstrate normal levels on subsequent rechecks. So usually our first step when a PSA is elevated is to test it again. So what is a normal PSA? Well, that depends upon age. The normal PSA is generally considered to be less than or equal to 4. However, serum PSA levels may actually increase with age. For men between 40 and 49, then a level of 0 to 2.5 may be considered normal. 50 to 59, 3.5, 60 to 69, 4.5, and men over 70, something like 6.5. And it should also be noted that some medications may actually lower the value of your PSA. Among those are statins, medicines you might take for cholesterol, thiazide, a type of blood pressure medicine, and NSAIDs, which are anti-inflammatory drugs, and especially true of the 5-alpha reductase inhibitors. Those medications like finasteride and dutasteride might be taken to actually shrink an enlarged prostate. Finasteride you might recognize as Propecia, which is a hair loss medication. So typically after 6 months of use, those medications might lower your PSA by as much as 50%. And while that might initially sound like a good thing, it's actually masking. If your true PSA level was 7 and you're taking one of those medications, it may only appear as low as 3.5, which might give you a false sense of security. So that's obviously another thing to share with your doctor. Lower risk patients include those not of African descent, who don't have a family history of prostate cancer, who are aged 40 or with an initial PSA less than 1, and those whose PSA remains less than 2 at age 60. And so the American Urological Association guidelines now advise screening those men in low risk could be done every 2 to 4 years, for those between 50 and 69. And once started, screening should generally continue until after the patient decides to discontinue screening after a shared decision-making process. especially if his reasonable life expectancy is less than 10 years, or the patient is older than 75 with a PSA less than 3. But at least one long-term study suggests that stopping screening at age 70 may be too soon. And then screening should continue or offer at least till 75 or sometimes beyond. But again, a lot of factors go into play. And patients in good health who wish to continue screening should be accommodated. But what about high-risk men? Well, of course, we might need to start screening them sooner. And high-risk individuals, again, those of African descent, a close family member with prostate cancer, especially if they were diagnosed before age 60, the family member had metastatic prostate cancer or even died from it, or just a strong family history of other malignancies. And we should also take note that Vietnam War veterans with known Agent Orange exposure may well have a higher risk for prostate cancer. And in those individuals, screening should start earlier, as early as age 40, and be conducted annually, unless the patient changes his mind about screening or he develops medical comorbidities that limit the reasonable life expectancy to less than 10 years. And then what about the DRE? Well, that's not Dr. Dre, not the rapper, but I mean digital rectal exam. So yeah, a lot of docs, a lot of patients will ask their doc, do I really need the rectal? And by itself, the rectal exam is not very good at picking up prostate cancer. Again, a lot of false positives, false negatives there. But it may well be a benefit in some men with elevated PSA, especially those higher than 2. But don't forget, it could also help pick up early issues like rectal cancer, hemorrhoids, other problems. So I don't discount the benefit of a rectal exam, but it's not the most important thing with prostate cancer screening. Now, there are some potential disadvantages to prostate screening. Overall, the survival is unchanged for the first 10 years after the initial diagnosis, at least in one study. And here's an interesting statistic. Between 70 to 75% of patients who undergo prostate biopsies show no sign of cancer. You know, and prostate biopsies, frankly, are not easy. But you know, unfortunately, to diagnose any type of cancer, we really have to have a piece of tissue. So most biopsies are negative and only tend to cause increased patient anxiety, discomfort, higher medical costs, and possible complications, including prostate infections, urinary tract infections, bleeding. And another risk of prostate cancer screening is that patients that are found with low-risk disease may ultimately be overtreated. For example, some men may undergo surgery, other medical treatments, who may well survive for many years without issue with their prostate cancer. A finding of low-risk, low-grade prostate cancer will not affect survival and can cause considerable patient anxiety and can easily lead to overtreatment. Side effects, complications that could have been avoided. So again, this is all part of the shared decision-making process of understanding the implications of a positive test, a positive prostate cancer biopsy. Way back in 2012, the United States Preventive Services Task Force recommended the elimination of routine PSA screenings. This caused a significant drop in overall prostate cancer diagnosis, but increased the incidence of higher stage disease, especially in higher risk populations. The previous steady decline in prostate cancer specific mortality rate flattened out and rose after the 2012 report, which led to a recommendation against PSA testing actually being redacted just 6 years later. So the long-term results of another study show that the PSA screening actually significantly reduced prostate cancer mortality. And numerous studies comparing PSA screened with unscreened populations followed for at least 10 years consistently show a clear 50% cancer-specific survival advantage in the screened groups. So there's a multitude of different guidelines out there, all of which are a little bit different, but I actually follow the American Urological Association, who currently recommends against PSA screening for men younger than 40, but screening those high-risk patients aged 40 to 5 may be offered. Screening for men at low to average risk may begin at ages 45 to 50. For men of low to average risk, ages 55 to 69, screening may be offered every 2 to 4 years. The recommended interval may be lengthened or even discontinued for men 75 and older with a PSA less than 3. And patients with less than a 10-year reasonable life expectancy are not likely to benefit from the screening. And again, shared decision-making regarding screening is critical in men between 70 and 80 who are otherwise in good health. So where do we go from here? Well, stay tuned. There are some new treatment options, screening options on the horizon. Currently we use the PSA test, but there are some other studies that can be done, including free and total PSA testing or an ultra-sensitive PSA, studies like PSA density or PSA velocity, which track the rate of change in the PSA over time. And who knows, down the road we may have a better blood test altogether. And I suspect that we'll also be able to better incorporate genetic testing into our screening protocols. MRI or imaging studies are now being used more and more to help in decision making. And the concept of active surveillance, meaning we don't necessarily intervene, but we'll continue to just monitor PSA over time. Well, thank you very much, and let me see if you have any further questions.
Thank you, Dr. Curran. We do have some questions. Can you reduce your risk for prostate cancer with diet and exercise?
Well, that's a very good question. We tend to think the answer is yes. We don't have a specific diet, but any diet that's rich in fruits and vegetables, whole grains, leafy greens, healthy fats, combined with exercise and maintaining normal weight is likely to reduce risk of multiple cancers, and prostate cancer might be included in that bunch.
Okay, thank you. Our next question, are there signs or symptoms associated with prostate cancer?
Well, another good question. The tricky part is that prostate cancer may present with no symptoms at all, or it may present with signs of urinary obstruction, decreased urinary stream, nighttime urination, increased frequency of urination. But remember, those are all signs of just normal prostate enlargement with age. So that's part of the challenge, is determining the difference between just normal aging and prostate cancer. But the short answer is you can't rely on symptoms as the guide. Now, some symptoms like blood in the urine, would deserve, more urgent attention. But that in and of itself is neither a sign of prostate cancer or proof of prostate cancer.
Okay. And our last question: once diagnosed with prostate cancer, are they diagnosed at different levels and aggressiveness?
Definitely, prostate cancer can run the gamut from being, very slow growing to being very aggressive and spreading throughout the entire body. So that's the challenge again of prostate cancer, is how can we identify those aggressive cancers early on that will benefit from treatment and have a positive outcome.
Thank you. Thank you, Dr. Curran, for this insightful presentation. This does conclude our program, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.